Actually, Dr. Hilton stayed with us for 3 months, and before he left, he gave us the inspiration to start the Retina Institute of Karnataka. He said, you need to have a Vitreoretinal Center, exclusive center, and that's how it started. I'm very glad to inform you that we are going to celebrate 20th year of Retina Institute of Karnataka this year. I'm going to look at some of the florid TRD cases and how I manage. Some of the cases that we see are like this, where there is a fibrous proliferation, chronic detachment. You can see the hard exudates in the near the arcades, and here the membrane has contracted so much the macula is pulled off. We do come across these situations in our patients who present to us very late. They don't come in time, and we end up with situations like this. How do we manage those cases? What are the problems we face? Extensive proliferation, as you saw. Broad adhesions. The retina has become thin, ischemic, and the vessels have become sclerosed. When you try to operate on them, intraop bleeding is one of the major problems that you can encounter. And with membrane surgery, retinal breaks do occur in these patients. Pre-op Avastin, we have used it, but not as a routine in all cases. Whenever the fibrous component is predominantly present, we don't use Avastin. If there is a lot of vascular component, I would like to use pre-op Avastin because it makes the vessels shrink and probably has less bleeding in the post-operative period. And I have a feeling that once Avastin is injected, when I dissect the membranes are more easier to dissect from the retina as opposed to a patient who has not had Avastin. I would like to learn from others whether they have had similar experience. Of course, the downside is increased interaction, but here we are talking about real extreme situations where the macula is already detached. Be careful in a patient where the macula is attached. In that patient, you would think twice before injecting Avastin. When the macula is already detached, you're not really bothered about mild increased interaction that might cause. Most important thing is you have to time your surgery well with pre-op Avastin. You have to do your surgery 3 to 10 days after the injection. So make sure you get your physician fitness, make sure that the patient is fit with blood sugars, renal clearance, cardiac clearance, etc. before you inject the Avastin. My approach is to use Avastin in selected cases. Today we use MIVS for all these patients, either 23 or 25. I am going more and more towards 25 gauge probe because I think the smaller, thinner probe gives us better ability to dissect the membranes without needing bimanual dissection. So generally, I do not use a belt buckle unless there are peripheral breaks that cannot be, where the traction cannot be relieved. Belt buckle is not a standard part of my vitrectomy for diabetic TRDs. And I often resort to bimanual technique with chandelier to tackle difficult situations. Let's look at some videos. Before we go on to the actual surgical, I would like to highlight 3 layers that we see in these patients. One is what is seemingly detached vitreous face that I am removing here. And you can see that this is the detached vitreous that you can easily see, identify and remove as you do the vitrectomy, the core vitrectomy or the truncation of the cone. Then once you have done this, you pick up the membrane and you think this is the second layer. And you think this is where I need to start my dissection. But beware, there is another layer below that, and you need to get to that layer in order to see another thin layer which is there below that membrane. That is the plane you need to get into. So I often tell my fellows that you need to get into the real plane in order to find or dissect the membrane. So finding the plane holds the key to the most atraumatic way to remove the membranes here. If you look at, can you have a pointer? Yes. See that the plane what we need to look for is below this layer. This is a thick layer. Below this, there is another thin layer that you need to lift. And once you do that, the membrane separates as if by magic from the retina. And then you can see a plane in which the retina is attached to the membrane only at certain nails. So in patients in whom you are able to get to this plane, the membrane dissection becomes easy. And often this step is done with, sorry about that. So the key to successful surgery in diabetic TRD is to find that plane. And this part of the surgery, generally I use a chandelier and I use a flat contact lens or a prism contact lens in order to give me that magnified and highly magnified and a clear view of the various planes, because the optical clarity with which you see with a flat lens or a prism lens is much superior to what you get with a wide angle lens. This is a patient who has, you can see that the posterior pole around the disc is detached, the macula is detached. The first step in my scheme of things is to detach the vitreous attachment to all this membrane, that is truncation of the. So the vitreous is not detached completely from this part of the retina also. Sometimes it can be, but sometimes like this it is not even detached from this retina. So I am trying to detach the vitreous from the retina and then cut off the attachments of the vitreous all round to this membrane. That is my first step. So in case the vitreous is detached, it's easier for you, otherwise this step could take a long time. You could dissect the membrane and then dissect it forward also. But my preference is to remove all the vitreous attachments to the membrane and then start the membrane dissection. But in some quadrants where the vitreous is firmly attached, we do the other way also. We don't persist in detaching the vitreous, we detach it after we detach the membrane. Now I put a chandelier and I'm using a bimanual dissection to do the membrane. And you can see that once you reach that plane I was talking about, you will see that the retina detaches quite easily, and all you see is tiny nail-like attachments of the retina in between. Between the two nails, the retina is free. It's not really attached to the membrane. Unlike what the membranes Guru Prasad showed, in PVR, the membranes are attached globally, and that's why, you have to peel them. Here, you have to lift the membrane and cut the attachments of the membrane to the underlying retina, like the nails. It's as if the membrane is nailed to the retina at several places, and when you reach the right plane, you just have to cut the nails, and then you are able to detach a large area of the membrane easily. See how once you separate that, it just separates off from the underlying retina much more easily. That's why I like bimanual dissection. You can see and get into the plane. If I use a probe for excising the membrane, I feel I won't be able to get into the plane so easily like what I do with bimanual dissection. Generally, I do not pull off the membrane from the disc, because I have burnt my fingers by pulling it off the disc, causing a ooze from the disc which I could not control. So generally, I dissect from all around the disc and then circumcise it and leave it attached. A stump is attached left to the disc. And this is, at the end, a fluid air exchange and laser being done. So we are able to remove all the membranes, and you can see that the retina looks fairly all right at the end. And like what Guru Prasad said with his PVR situation here, also you need to be patient. And in addition to the problems of retinal breaks here, the bleeding, that is one thing which really can be a killer in a situation like a PDR. I'll show you another video where a clot has to be removed. Do not allow the blood to clot on the retina, because the retina and the clot become so inseparable. It's easier to separate a membrane, but a large clot stuck to retina sometimes is impossible to separate, and you end up almost abandoning surgery in these situations. So do not allow much clot to really adhere to retina. That's one of the important things that I would like to tell you. Try and cauterize and remove the blood within a short time to avoid a clot situation. Again, bimanual surgery, And here I'm just showing how the nail is there. You just cut. Here I'm using the probe as a cutter here. You can see that you just define, you just push the retina and create a plane, and you can see a small nail there that you can cut. And then once the membrane is cut into several pieces, you can always excise and continue with the bimanual surgery after excising these large sheets of membrane. And this is the picture at the end. You can see that all the membrane is removed, maybe a small stump is left there, and then we are able to do a fluid air exchange and silicone oil. Membrane surgery with a probe. You could use the probe. Probe can work almost like scissors. When you see some of the cases, you can actually almost see as if it's working like scissors. So you can see that you can go and then just activate the scissors. This is the magic of modern vitrectomy machines with a high cutting rate and the duty cycle, which can be altered in order to make the vitrectomy probe work like scissors. So you can see almost by magic. See, you can see that the whole membrane can be dissected, but here this membrane had much less attachments, much less focal attachments to the retina compared to the previous ones, and therefore we are able to do this in this patient. But in at any time you feel you are not able to really remove the membrane with the probe, you can always switch over to bimanual dissection. So that's again the end result. So use of probe as a dissecting membrane is possible. This is the last video I wanted to show. This patient has this clot stuck to the retina. It was so firmly stuck that I had to use actually bimanual dissection, and you can see that the fibrin is so strongly present here that it has made the clot adherent to the retina. You can see that it is difficult to separate the membrane from the retina, and this is one situation you have to avoid. So if you get a bleeder, raise the pressure, make the this one stop. In fact, what happened in this patient was I did not have scissors. I wanted to use forceps and scissors, and I did not have a 25 gauge scissors available to us in a sterile way. So actually I converted one into a 23 gauge so that I could use a 23 gauge curved scissors. So here I can see that I'm using a 23 gauge curved scissors to actually separate the clot from the retina. And once you have a clot stuck to the retina like this, along with some part of the membrane, the things become very, very difficult, and sometimes you have to probably even abandon or give up, because you cannot separate the clot and the membrane both from the retina. So that is one situation you should avoid. You should try and cauterize, raise the pressure, cauterize the bleeders, and avoid such a large clot collecting on the retina. And in the end, I actually went back to the 25 gauge, and these are some of the results. Counting fingers 2 meters, you see 2 months post-op, vision 636. And another patient with almost the retina is bunched up near the disc here with a foveal detachment, and you see the result post-surgically. This patient had such a heavily vascularized sheet which covered the almost the entire inferior part of the macula. And this is the post-surgical results. So in conclusion, florid PDR, TRD is common in our situation where the patients present to us very late. I do use Avastin, but not in all patients. Like the patient I showed you last, I would use Avastin. Like this patient, I would probably use Avastin. And I used Avastin, and the retina actually got lifted before we could, after using the Avastin. But in this patient, probably I may not use Avastin because the vascularity is not so much. So judicious use of pre-op Avastin does help. Not a routine use. I wouldn't advocate that. Most membranes can be removed. You need to use a combination of techniques. I have shown you some techniques which I found to be most useful. But of course, the bottom line is because of the ischemic retina, sclerosed vessels, thin retina, visual results are often poor. But these are desperate situations like what Guru has told you. and we do need to resort because whatever vision patient can get is useful to him. Thank you.